Hey, what's up, and welcome back to Basically EMS, everybody. We've been gone a little while because our boy Wade was gone. Where were we at, Wade?
I wasn't having a baby. My wife was having a baby, and I was supporting her.
Yeah.
But yeah, been dealing with that, and dealing's not the right term, but it's been an experience.
A brand newborn, it just kind of feels like you're dealing with things sometimes.
Yeah, my eyes are they're almost gluing themselves shut. But
That's cool.
That's showbiz.
Yeah, that's all right. That's just make sure you're doing an audio only version of this, and it won't matter, right?
Yeah.
Yeah. So that's where we've been. That's why we were off a little longer than normal. Wade was off, becoming a first-time dad, which is pretty exciting.
Yeah, it's fun. It's fun, horrifying and terrifying, but fun.
Yeah. So we're going to talk about anaphylaxis, which is really terrifying as a parent because this happens a lot with kids.
Kind of like a quick thing is that the first night we had her in the bassinet, it's next to our bed. I'm like, oh, I'm so hungry. It's like 3 a.m. And I went and made a peanut butter and jelly, and then she cried, and I'm like, well, hold on, I can so it's very quickly jumped to my mind.
Yeah. Which is it's a fair thing. That's the best and worst thing about being EMT, paramedic, parents is like you know how to fix things, but we sometimes forget how rare, all the things we see are incredibly rare, right?
Right.
But sometimes you forget that as a parent, and you're just like, my kid's gonna be allergic to everything, and I'm gonna have to I'm just gonna have to buy an EpiPen just to have one in case, which is not reality.
She's gonna get peanut butter in the ER parking lot the first time. I already know.
Yeah.
Pre-planning.
Yeah, it's a weird thing. Anyways, that's what we're gonna talk about today. Is gonna be some allergy anaphylaxis. So let's hop right into it with the pathophys of anaphylaxis, we will differentiate anaphylaxis versus allergic reaction, but just in general for allergic reaction, the pathophys wise, it's really important for people to recognize that the reaction is not the substance. It's not the peanut butter. It's not the strawberries. The issue is our body's reaction to that substance. So that substance will be called an antigen, right? So antigens are substances from outside that are introduced into the body that for whatever reason, the body's defense mechanisms just go nuts for and have an overreaction. So it's important to remember that when we're talking about allergic reactions is that it's not an intrinsic internal thing. It's the intrinsic response to an external antigen. Right?
I usually think of it, like you said, like it's an overreaction. And like the way I'll talk to my students with it is, you're talking to your body and it's like, I told you 5 times I don't like peanuts. Now I'm going to kill you, right? It's just a massive overreaction to something that you've probably had exposure to before. Because not every anaphylaxis isn't most of the time from your first, introduction to a substance. It's that repeated that typically will cause that anaphylactic reaction.
Yeah, and a lot of the time they get worse. So you might have a very mild anaphylactic reaction, and then the next time it gets worse, and it gets worse, and it gets worse. And so that's one thing to really be cognizant of when you're working in EMS. If somebody has had a reaction before, it might be worse this time because that's just what the body does sometimes. Last time they sent out, half the army. This time they're sending the whole army out to attack.
And it's progressive too. I had a friend through high school. He was allergic to strawberries, but he loved strawberries. So every time we'd go to IHOP, he'd get those strawberry pancakes. And at first it was, him licking the roof of his mouth like a dog because his mouth would get itchy. And then it's like, dude, your face is starting to swell up. Your tongue is starting to get big. And that was the change. So I feel like strawberries, sorry about it.
Yeah. So you might have an allergic reaction to an antigen. And you might also have like a anaphylactoid reaction, which is a term that's used for a reaction to something you've had all the time. Like I don't have any allergies, but if, tonight I went and made a smoothie with some strawberries and I had a reaction to that, that would be an anaphylactoid reaction. So there is that differentiation. That's a hard word to say.
Differentiation.
Thank you. There is that, that difference from one to the other. Which can really trip us up in the field as providers because, if you have somebody who's complaining of signs and symptoms that seem like it's like, an allergic reaction, you're going to be like, well, did you eat a peanut butter sandwich? Do you have any allergies? And they're like, nope. And then it's like, wait a second, is this actually an allergic reaction? So it's important to recognize that we can have reactions to stuff we have not had reactions to in the past.
Right.
And so we need to be really good detectives of finding these signs and symptoms, and then we'll get into treatments later, but This is one thing that we generally are pretty aggressive on our treatment
yeah.
for.
Yeah, I mean, we kind of talked about it, and we'll get into it more. But it's an abbreviated primary assessment because ABC is immediately. I mean, depending on the severity, I know you've had calls just like I've had calls where you walk into the rooms like, oh, that's bad. I don't even have to see them; I can hear them around the corner. So yeah, it can be a quick thing. I think an important thing you kind of touched on it, but just to kind of cover it, right? The difference, especially when it comes to like an NREMT perspective of allergic reaction to anaphylaxis, right? An allergic reaction is a systemic response, like you were saying, but it's typically an isolated body system.
Yeah, single system.
Right. Yeah. So like my buddy I was saying, like his mouth got itchy. Isolated system. When it becomes anaphylaxis, we're talking 2 or more. So airway, GI, airway, skin GI, right? It can be all sorts of variations there.
Yeah, so that's what's going to differentiate anaphylaxis versus a typical, just a simple allergic reaction. And a lot of the time, anaphylaxis will affect the airway.
Right.
And so that's what we need to really be concerned about. So what happens in the body essentially is whatever antigen gets introduced to the body recognizes it, and it's going to send out a bunch of leukotrienes and histamine. And so it's important to recognize that that's what the body is doing and what those things do to the body, essentially. So those are going to be sent out to the body, and they are very it's really hard on the cellular walls. And so this histamine will come down and it will break those cell walls down. So it causes pretty widespread vasodilation. So the container gets bigger. We need to always be thinking about that. And it will make sense when we talk about signs and symptoms. But, the container gets bigger. And then it also becomes really porous, which is really important for us to recognize, which is why we're going to see that swelling. If you get stung in the arm by a bee, a lot of the time that arm's going to swell up because it's sending all that histamine to the area to fight that histamine, the leukotrienes, all the immune response. It's trying to fight it, and it's going to really turn those vessels into Swiss cheese. And so we're going to see that swelling, and that's because of that. And then we're going to see that widespread vasodilation, which is going to lead to, other symptoms that we'll talk about.
Yeah. And I think I think the description of cells turning to Swiss cheese is fantastic. The direct verbiage they're going to probably see, or you might see, is increased cellular permeability, right? So the more permeable something is, the easier things can pass through. So if you're listening to this and you're planning or you're studying for your NREMT, just don't be surprised. That's what it means. Like Chris said, that permeability, more stuff getting through. Swiss cheese, we have blood escaping cells and substances escaping cells a lot quicker.
Yeah, which is going to cause all sorts of issues. So swelling and then hypovolemia and all that stuff. And it will lead, as we talk into anaphylactic shock, like how all those things are brought about with anaphylactic shock.
Right. We already kind of talked about it, kind of transferring straight into anaphylaxis here about the multi-systems and airway being the big one, right? The tongue angioedema, that tongue swelling up, or even just the face, right? Like the throat swelling. But a big one, urticaria, big fancy word for hives. I'm sure anyone who's had an allergic reaction before to even just an isolated reaction knows what those hives look like, feel like. They're itchy. They're what's the word I'm looking for? They're not spreadable, contagious. I've had that argument with some people, like they got hives, it's contagious. Absolutely not. They were having a reaction, right? But that's the skin sign, the big one we're looking for, and that kind of helps classify anaphylaxis to allergic reaction. I
do want to caution that people sometimes don't realize, though, that urticaria is only present in like 60 or less %, I think, of anaphylactic reactions. So, and I've seen that a lot with students of like everything else is like pointing right to it, right? The 8 shellfish. They're wheezing, they're hypovolemic, they're tachycardic. Everything else is like anaphylaxis. There's nothing else. And the student's like, well, how does the skin look? Like, it looks flushed. Do I see any hives? No, there's no hives. Like, oh, well, it can't be anaphylaxis then. And then totally, miss the forest for the trees, as you will, right? Like, so don't fall into that trap of only assuming of assuming every time you're going to see hives, because that is not the case. It is a very good indicator, but it is not the be-all end-all.
Right. Multi-system. Remember, it doesn't have to be skin. It could be GI. If they're like, you see airway swelling and they're like, I have just diarrhea uncontrolled. There you go. 2 systems. Yeah,
which kind of leads us into some common allergens. And so this can kind of dictate signs and symptoms. So food allergens are going to be a common one, right? We talk about it a lot with like with tree nut allergies or strawberries or that kind of a thing. That's a super common thing. And so a lot of the time, symptoms specific of that is where we're going to see that GI upset. So, which I know as an EMT, I was never even crossed my mind GI. I never thought about it. But having been in the field, especially with like kids and little kids, if mom and dad are like, we tried a new food and they're just not acting right and they've had really bad diarrhea and they've been throwing up, like, oh, maybe it's an allergic reaction to that. And it makes sense if you think about, a bee sting's not being introduced into the GI tract.
Right.
But food being introduced to the GI tract is going to have that irritation as it attacks that antigen at the site of where it's being found.
Right, because you're still going to have the interaction with vasculature through the GI, right, for absorption of nutrition. So it's just going to be at that point, like you're saying, it's in that wall of the organ involved.
And a lot of the time that's going to be a slower process. So, if we're talking about like medications, like an IV med, I don't know if I've been on calls where patients were at like an infusion clinic and they got something new in an infusion and they had an allergic reaction to it. That's like instant, right?
Yeah.
Because that's directly into the circulatory system, where this is probably a little slower. You're going to eat that strawberries. And if it's a GI thing, it might be broken down over a while and then start to, build up more and more. And so this isn't necessarily something where they have this happen. Right. And it can happen very quickly, but this might take a little bit longer.
Yeah. Typically the standard number they throw out is 30 minutes, which is your typical digestion time. But it can be quicker. Story I had, it was in a local area here. We have kind of an outdoor mall area and there's a jungle gym for kids around us. And there happens to be a very popular national chicken chain around the area. And when we got there, mom was in a tizzy, had already administered the EpiPen. He's throwing up, his throat is starting to swell. He's crying, he's screaming. It doesn't sound raspy. It sounds like resolution from the epi. Obviously we're going to have to redose this kid. But I'm asking mom, I was like, well, what's he allergic to? And she's like, eggs. It's like, okay, well, did he eat any eggs? Is there any eggs around here? And she's like, no. But I asked for the no eggs on my Cobb salad. And so what our running theory is that, the employee who pulled the eggs off didn't change gloves and then touched kid's food, and then kid ended up having a reaction. So sometimes you're going to have to do some digging. I would also kind of find solace in the fact that you might not know. There's so many times it's like you can be as good a detective as you possibly can, but with bigger fish to fry, an anaphylactic kid in front of you, or a person in general, sometimes it's about dealing with the response and not finding the answer.
Yeah. I mean, again, we're not quite talking about signs and symptoms and treatments yet, but like a lot of the time we're just treating symptoms. Right. And so maybe you're not exactly sure what it was, but if you have those symptoms and like, everything's pointing towards it, even if you can't hammer out exactly like, oh, it was the eggs, right? Like if he's got an allergy and everything's pointing towards anaphylaxis, we just need to assume there's a contamination somewhere and we need to treat it.
Right.
And also why, we preach a lot about being a detective and asking good questions. And that's exactly what we're looking for. Again, students fall in the trap. We're not always great about making students be good detectives because we want to get them to the end goal of like finding a thing and whatever. And so this is the difference between an easy school scenario and a real life thing of like, we're not generally going to give that in a school scenario. It's honestly just too easy. So where when we get out into the field, you're going to have to deal with those kind of things.
And it's tough too, because even the times where it's like, oh, this feels so easy when you're in school, recognition in real life is the game, and it's not always as obvious as you'd think. And like that kid, he didn't have many hives, just throwing up and the airway swelling, but just you could tell his skin and his cheeks were flush. He'd been going through it, know, and sometimes just acknowledging the little things is going to be the biggest difference maker.
And recognizing that if you have all those pieces in place, the treatment, especially, that's the nice thing about basic EMT treatments, is they're pretty like, if we weigh, the cost versus like the danger, right? Or the, the outcomes versus the possible dangers, like they're way pretty safe.
Right.
And so, for the most part, if you have a kid that doesn't have heart issues or anything like that, if you give them a little bit of epi because you're concerned about it, the worst thing is they're going to get a little jittery and they're just going to feel like they have an adrenaline dump, and that's going to be fine.
Yeah.
If you're wrong, right? Like if you're wrong, you're probably not going to do any harm. So,
caveated, right? Just be careful with your meds, but still, right?
yeah, don't
Worst case.
be cavalier out there just throwing epi at everybody. But if you're on the fence and all signs are pointing, like, and especially if you're like, oh, I have these symptoms that epinephrine could possibly treat, then it might be okay. Or, just call medical control and be like,
Right.
I have all these things. I'm just not sure. There's no obvious thing. Either there's no obvious story narrative that I have that says it's exactly this thing. But here's my, and I've done that a lot of times. Like, here's my suspicion. Like everything else is matching. I'm really concerned. What do you think about this? Right? Like one of the craziest STEMIs, heart attacks I've ever had, didn't meet criteria on the EKG, but just spidey senses, all the other pieces of the puzzle fit. And I was like, I'm going to treat this. I'm going to be aggressive about it, and I'm going to play worst case scenario here. And I called the hospital, sent the EKG over, did all the things that you normally would do. Yeah. And I even called and said, hey, you'll see. I understand the EKG is not meeting criteria. Everything else fits though. And the doctor agreed. They're like, cool, bring him in as a STEMI. And then halfway through he started vomiting and his EKG changed to the gnarliest I think I've ever seen. And it was bad. Like we're just like, don't die. Please don't die. Don't die in my ambulance.
Yeah, not the ambulance.
It was gnarly and he survived and, from what I was told, had a full recovery and everything was good. But, especially considering the situation like that when we were, I don't want to say, we tried to stay away from like specific places here, right? But we were on a more rural road outside of town, and it was like a 30-minute transport to the hospital, right? Like, you don't want to play those games.
Right.
Be aggressive, use your resources, and be ready for it.
And with experience, a lot of this comes with experience, right? Of like understanding, okay, this is what I'm seeing, but like realistically, how much time do I have, right? Like if I'm less than 10 from a hospital and someone's like, I ate food like an hour ago and I'm starting to get a little scratchy and like a little itchy, but they're not presenting all the way. You don't have enough to really sell it as anaphylaxis. Maybe I just draw the epi up and I hold on to it, and I can withhold that. But like I said, there's a huge caveat. Let your experience guide you there. If you don't know and you're not sure, medical control is always your answer, right? They're going to help you one way or the other. The only thing is, remember, sometimes I've been in plenty of situations. There's no cell service. Choices got to be made.
Yeah. You can't fully rely on it, but don't forget that's a resource.
Always.
Little off topic. Let's get back onto it. Yeah. We talked about food. Medications are going to be another common one.
Penicillin.
Penicillin's huge in the older population. I don't know what it is about that specifically.
I can tell you. So it was because of how frequently it was used, because penicillin was the wonder drug for everything, right? And so that was the only antibiotic used for so long that people developed a resistance to it and then became a congenital resistance.
Interesting.
Yeah.
Well, I mean, it makes sense, right? Like I've had so many old people like penicillins, or some people just all the cillins are allergic to. So those are pretty common. NSAIDs are going to be another common one that you might see. So non-steroidal anti-inflammatory. So Advil, ibuprofen, acetaminophen, those kind of things.
Yeah. So one thing I do want to talk about in here with meds, it's our treatment med. Is that I've gotten this question: what if they're allergic to epi? Realistically, is it impossible? I can't say absolutely not. Though I did a lot of research into EpiPens, and it tends not to be the epi that people are allergic to. It's a sulfide-based preservative that they're allergic to. So when they're like, oh, I'm allergic to my EpiPen, not quite, right? Because the body makes epi. Like, once again, is it impossible? Can't say no. But I can't say yes, it's impossible, excuse me. But, keep that in mind too. And because I've just had so many students ask, well, what if they're allergic to epi? Are we just, up a creek? It's like, kind of, but also we don't use the same things, right? We're using non-epi pens. We're drawing up our own epinephrine. Yeah,
there should be no possibility because we produce, epinephrine, we're just giving the same thing that our body produces, right? Our body produces epinephrine from our adrenal glands. It's already there, so there shouldn't be that, but that can be the case of being allergic to that. Like there used to be, what med was it? It might have been ipratropium bromide. That there was like big concerns about people with like cherry allergies, right?
And shellfish was on that list
It was
too.
shellfish.
Yeah.
And what they found was there was just a preservative that was put in that medication, or preservative or something that was derived from cherry pits or shellfish or whatever it was, right? And so that's just one of those long-standing things where, like, when I went through, I think EMT school, it was still a thing, but by medic school, it's like, oh, it's not really a thing anymore. But the old school guys just didn't get it, and there had to be some re-education. Like, well, it was just because of how it was produced. They're not allergic to. It's not this, right? It was just because of what else is in those meds.
I think I might have gotten shellfish with fentanyl. I think that was one that they were using fentanyl preservative that was a derivative of shellfish. My bad for the misinformation.
Yeah, and this is older stuff, but when you're out in the field, you'll find out about this stuff. So just keep that in mind, that a lot of the time it could not necessarily be the med itself, but something else that is part of that medication that allows us to administer that medication.
Yeah.
So meds can be administered obviously a couple different ways. It's important to remember they can come through the digestive system, right? We have, they call them enteral versus parenteral medications. So enteral will be through the digestive tract, whereas parenteral are going to be outside of the digestive tract. So there's a little National Registry knowledge for you. And so the amount of time you have before the body reacts to this could be significantly different. An IV medication being pushed is going to be more or less instant versus an oral medication is going to be longer.
Right. And the general way I remembered it was the faster it hits the bloodstream, the faster they react, right?
Yeah.
So if we're getting an IV, it's obviously straight to the bloodstream. If they got to eat it, it's going to take some time to digest and break down. If it's something on the skin, it might take some time for the transdermal effects to start going on. It's just, if you remember, the faster it hits the bloodstream, the faster and harder the reaction hits, you're going to be okay.
Yeah. Yeah, I had kind of it's not funny. It wasn't funny for the patient, funny for us. A call where somebody was in an infusion clinic and got an IV with something that they said it was giving him an allergic reaction. So the doctor of the clinic went to administer Epi. And from what I could gather, they gave the 0.3 or 0.5, whatever, of Epi, but they didn't do it IM. They did that IV. And I'm pretty sure they gave, so the Epi, and I'm sure we'll talk about it later, the Epi we give IM is a 1 to 10,000 medication, where IV is 1 to 1,000. So it's much more concentrated. I'm pretty sure they gave like half a milligram of cardiac Epi in the IV. And it was just interesting talking to the lady because she was like flushed and hypertensive, and it came down as we were transporting her. But I was like, what are you feeling? She's like, now I feel okay, but I just felt like my whole body was on fire. It's the worst experience I've ever had. I thought I was going to die. My heart felt like it was going to explode, but I just felt like my skin was just going to burst into flames. I was like, ooh, it was gnarly.
Yeah, that's one of those situations where you're like, well, it sucks to be that guy because I'm not going to, own the mistakes if you make the mistakes, but some of them are harsh.
That was a bad one.
Oh, man.
Moving down, plants are going to be another thing that we can see allergic reactions to. So, that could be ivy poison oak, those kind of things, pollens, all sorts of different things.
I'd say just be familiar with the plants in your area. Not obviously no one, well, maybe you are, but I'm not going to pretend like I know every single plant that exists in this, high desert biome we live in, but it's a sagebrush, the little things, the poison oaks, poison ivies, be just loosely familiar, right? Especially poison oak, poison ivy, be able to identify, because you want to talk about seen, not safe. Walk into that and you'll figure things out real quick.
Yeah, and there are plenty of people that have really mild allergies to plants too, right? Like the seasonal allergies are just going to be super mild allergies that are not going to cause any anaphylactic reactions or anything like that.
Right.
Just be aware that is an allergy. It's just a very mild allergy.
This comes back to that 1 to 2 systems, right? If it's 2 systems, we got to be a little bit more concerned. If they're having just a snotty nose, that sucks.
Yeah, runny eyes, snotty nose. We're definitely not going to give them Epi.
Right. No. No.
Not qualifying.
Not yet.
Chemicals are another one that we're going to see. The big one for healthcare is going to be latex. And I haven't seen latex gloves in 10 plus years.
They made the best balloons. I remember that from when I was a kid.
Yeah. but they're just not common anymore. So that's one thing to be aware of. Maybe like latex allergies. If you, I don't know anywhere. I doubt they really make them anymore, but it is a possibility that I guess there could still be latex gloves out there.
That's one I ran a call for a person who was allergic to latex and they had a reaction because of the contraceptive they chose there. So sometimes it's not obvious, but another one is, and this is the thing I feel like I've seen a lot of students get tripped up on, is they run through their sample and they haphazardly do the sample history because I got to hit my points, check my boxes, right? But like pay attention, because sometimes they might say something. It's like, oh, I'm allergic to this brand of soap or this brand of shampoo, right? And it's like little things, or like, what's your laundry detergent? I've asked so many of those questions, and it's stuff that like if you hear a doctor or you hear another provider asking, like, oh, that's a good one, I'm adding that to repertoire. 'Cause, I mean, even there was a person out of the local prison, one of the local prisons here, who he had like multiple allergic reactions because of the detergent they were using in clothes. This wasn't my call. I was talking to the medic who ran it though, and like they literally ran him like 3 different times because there's like they change the soap reaction, change the soap reaction. So keep in mind it's not always obvious, right? Do the digging once again, but just ask the questions. If you're not asking questions, or you stop asking questions and you still don't have an answer, you're not doing a good enough job. You got to keep digging.
Yeah, and it could be all sorts of things, right? Like you said, like laundry soaps. My little sister is the same way. I remember as a kid, she always just had welts, and it took a long time for my parents to figure out, like, oh, it's whatever, like laundry soap, and they had to get a different laundry soap, and it went away. And her, I think, at least one of her kids has the same thing, right? Like it could be all sorts of things, and so, that's one of the really important things to ask if you're suspecting an allergic reaction, is like, what has changed between when this started and before? Like what new has been introduced, and ask those questions. And maybe it's a food, maybe it's a medication, maybe it's laundry soap, right? Like it could be all sorts of different things.
Remember, it might not even be a brand new thing. They may have been the second time you're using this soap, and that the first time they're like, yeah, it was a little itchy, didn't think much of it. Second time, there we go, anaphylaxis.
And then coming down, the last kind of major category is going to be insect bites, right? So, or stings.
This is a trademark one.
Yeah, like that's really kind of if you're going to get this this kind of patient in school, it's probably going to be food allergy. I do food allergy all the time when I'm giving scenarios, or a bee sting kind of a thing, right? Bees, wasps, whatever. And so those are generally going to be pretty quick because those are going to be injected, right? So it's going to be, those reactions tend to happen a lot faster than like a food allergy would. Right. Which is important to think about.
Yeah. And then depending on, what they got into or what got after them, right? If you think about things like wasps tend not to run by themselves. Sometimes you're going to get into multiple, and just remember, if they're allergic to one wasp, imagine what 10 are going to do. Yeah. It's going to change the circumstances.
Yeah. And it's important to think about kind of along those same lines, right? Like a bee typically will sting once and the stinger stays. And when they leave, it just tears out, and then that's it. They're one and done for a sting. Where there's like wasps, hornets, all that, they can sting multiple times. And so that's just increasing the amount of antigen that's being introduced to the patient. So,
and wasp bite, for record too. You're getting it from both ends from them. Yeah. Little things.
They're kind of the worst. Yeah. Bees are cute. Yeah. Bees do great things for society.
Leave the bees alone.
Wasp are a different story. No, thank you.
Burn them.
So yeah, it's important to remember, if it's fire ants that people are allergic to, whatever, that even maybe if it's a mild allergy, but they get caught by, they step on a red ant colony and they get a bunch of bites, it can progress to be much more significant than it has in the past, just due to the nature of how much they're being introduced to.
Right. And this is I completely forgot about this till just this moment. A call that came out, one of our old coworkers was telling me about it, like when we were working there, and it was a guy who was not paying attention, and he was eating out of a bag, and he put something in his mouth that bit him, and he was allergic to spiders. And oh man! So yeah, keep in mind, it could be a weird spot too. But, man,
that's like a Dr. House kind of a thing.
Yeah. Final Destination. It's coming for you, dude.
That sucks.
Also, watch your food. I don't know. I feel like,
I mean, I get it. You're like watching TV, just munching on some Doritos, right? Like you're not looking at the Dorito bag.
That's fair.
Because then you're going to see how much is left, and you'll be like, oh well, I should probably stop, right? Ignorance is bliss if you can just keep going without looking,
That's fair. That's fair.
you know. Insect stings are going to be one of the more common deadly allergies. And a lot of patients, according to our notes here, like upwards of half of patients that are killed by insect bites have never had that reaction before.
Right.
So that's an important thing to think about.
And accounting for around 62 deaths a year. So that's around 30 people have never been stung by a bee, which what a good life. If you've never been stung by a bee, like you got stung by a bee at 40.
Yeah.
Good for you.
I say that all the time to my kids are terrified. I'm like, you've never been stung before. What are you terrified? Like, you know what I mean? I guess I'm scared of like being bit by a snake, and I've never been bit by a snake, but like,
I feel like that's different.
I
feel
agree.
like that's different because, yeah, we'll get into that later.
Snakes are just, ugh.
The big one with bees, though, is that stinger, right? Like, absolutely do not use tweezers to pull them out. All you're doing is a hollow spine full of poison. You're just going to squeeze that in, or toxin if you want to get particular. You're going to squeeze that into the patient, right? So it's always scraped out. Credit card is a great one. I've used tweezers before, obviously not pulling them, but pinch them together and then use the side of the tweezers to get them out. But yeah, some sort of rigid object.
Yeah,
That's your best bet.
You don't want to use tweezers or something and essentially milk it to push it further in. You need to
Right.
scrape it out. So, and that's one thing I feel like our students are just always like, they remember that. That's a real easy thing to remember. And you want to try to remove it quickly. If you get there and it's not removed, try to get it out, because it's going to continue to infect the patient, or not infect, like inject the patient with the venom if you don't get that stinger out. So that should be a quick thing for you to get that out as you're treating that patient.
Right. Especially keep in mind, you're going to have to find it. These are not big, obvious things all the time. Now, most of the time you show up and they're fairly conscious, be like, where'd you get stung? I got stung here. They're going to show you. What's worst case scenario of this? You show up and they're unconscious, unresponsive, airways closing. What happened? They got stung by a bee. Well, they're not going to be able to tell me where they got stung. This is kind of tying into the, as we move forward with your assessment stuff, like get a thorough secondary, right? Like treat what you got to treat early, get oxygen going, get that epi going, which we'll talk about in a little bit. But, make sure you're looking and doing your due diligence there.
You want to kind of start talking about some signs and symptoms we're looking for?
Yeah. So the big ones, right? Signs, symptoms. Anytime, if anyone's ever had any, especially when it comes to, rephrase. Let's talk about signs and symptoms when it comes to insect type stings, right? So if they get stung by a wasp, they're going to have some immediate pain, or a bee, whatever. But then just generally moving into anaphylaxis, we're looking for swelling, right? So it's going to be heat, localized heat. If you think about swelling, it's just blood being pushed through, right? And blood does a couple of things for our skin, gives us color, gives us temperature. So if there's a lot of blood there, they're going to feel really warm. It's the same thing as if you sprain an ankle and you feel that ankle while feeling the other ankle, the sprained one's going to be warm because of all the blood that's there. Potentially that widespread urticaria, so getting those hives, make sure we're double checking, being thorough. Like Chris said, only 60% of them or so, right? But doesn't mean we can't look. Always double check the chest, always double check the abdomen. I would even push to double check the thighs. I've seen those kind of 3 spots be big presentation areas for urticaria. And it's one of those things too, that if you're moving quick, it's something that's really easy to overlook. But as soon as you see that, like a lot of our students will fall into that, but that's your immediate recognition most of the time. Once again, not always, but if you see it, you're guided, right? And then itching, that's going to be a big one there. When it comes to the upper airway, right, we talked about swelling. Big sound we're hearing is stridor, right? So the high-pitched, sing-songy, the only upper respiratory sound that we ever really talk about, stridor, is always in that throat. Think about anything that's occluding an airway. So even if someone's choking, you might hear that stridorous sound, right? That high-pitched whistle that comes and goes. Now, depending on the severity of the anaphylaxis, moving down, you get things like bronchospasm, which is going to tie to wheezing. So you'll hear that whistling sound, and you're going to be like, oh, is that throat or is that lungs? Does it matter? At a certain point, epi covers both, right? Get involved there. So kind of with that, difficulty breathing with bronchospasm, so chest tightness, difficulty breathing in general. And then imagine the anxiety, right? So put yourself in these people's shoes. If this was you and all of a sudden you got a sharp pain, something happened, and now you can't breathe very well, they're going to be pretty panicked, right? Bring the calm to the storm. This is where we got to stay level head here. And then like we were kind of talking about earlier, other complaints, GI complaints, nausea, vomiting. For the most part, that's kind of the big three, though. Skin, respiratory, GI are the big three you're kind of going to see. But it can be any mishmash of presentation there.
Yeah, we need to remember, too, that this can progress to shock, right? So we need to talk about like standard shock symptoms. And we talked earlier about that those leukotrienes, that histamine release and what that does to the cell membranes, the increased cellular permeability and all that. It starts to kind of tie in and make sense, right? So I am going to start to swell. And if I'm swelling in my airway, that's going to cause constriction. So it's going to cause, depending on where that constriction is, we can have that stridor or we can have some wheezing, right? So that makes perfect sense if you think about that. On top of that, you're just going to have some general constriction of the airways anyways. And the way it was described to me is like, it's closing the gates to the castle, right? The body recognizes something that I don't like is I'm being attacked and I'm going to not allow any more of it, right? And so the airway starts to shut down and it's going to be swelling from that leaky fluid, the leaky cell membranes allowing those airways to swell. So we need to be thinking about, obviously, like you were talking about the ABCs.
I don't think I've ever heard that before, the guard the castle. That's good.
Yeah,
like
it's always been a good visualization to me of like, oh yeah, that's why it's closing down.
Yeah.
So airway, we're going to be seeing that. Some other symptoms, we're going to be seeing some increased respiratory rate, and maybe you're going to be looking for that, those signs of increased respiratory effort, right? So you're going to be looking for nasal flaring. You might see that good tripod position is very common for these patients as they're trying to open their airways. That's why we sit in a tripod.
Or that sniff too.
Yeah, the sniffing position. You might see some accessory muscle use, all those things.
Some 1 to 2 word dyspnea shows up.
Yeah, the standard respiratory complaint kind of signs and symptoms we're going to see in these patients because their airways are so tight, right? They're breathing through a coffee stir instead of a big straw. So you're going to see a lot of that, and it all makes sense if you think about what happens in the body. Then moving down kind of to the circulatory system, same thing we talked about before. Those veins and arteries get bigger and they become leaky. And so if we're thinking about our perfusion and our perfusion triangle, right, as the vessel that holds everything gets larger, as the pipes get bigger and they start to leak, the pressure within that system is going to go down.
Right.
So it's important to remember that's going to happen. So we'll probably see pale skin, except, we can see pale skin, but typically that urticaria is going to be bright red with pale behind it, right? Is a lot of the time what we're going to see. And if I have a bee sting on my arm, that's going to be really flushed and red, and I might have some pale extremities outside of that. So that's not uncommon to see some pale skin. Or it could be flushed as well because all that blood is being leaked out into the skin too. So you can see kind of both ways on that.
Right.
So make sure you're just really looking at skin.
And pro tip stuff, if people are stung on the arm, hand, whatever, jewelry needs to come off very, very quickly. You can Google all sorts of horror pictures of swelling around a ring.
Yeah.
If you can get it off, get it off. I will also say, if you can pull it off before you have to cut it off, you'll never make an enemy like an old woman who you just cut off her widowed husband, her wedding ring. She's going to hate you for the rest of her days. There might not be many, but she's going to hate you. I promise.
I mean, they can, hopefully she has more days.
Yeah.
And that's why you did it.
Yeah. We're doing a good job.
But yeah, and they can fix that stuff, right? Like, don't feel bad if you have to cut a ring off. They can take it to a jeweler and have it fixed, right? It's a lot better than them losing a finger because
for sure.
Because of the swelling around it.
Depends on who you ask, but yeah, I agree. Sentiment, I agree.
Fair enough. So yeah, we're talking about the circulation, right? So we have the skin signs. And if we're thinking about compensation, as the size of the vessels get larger, we need to keep that pressure up. And so the heart rate's going to go up. So tachycardia is a very common thing that we're going to see for these patients. So keep that in mind. You might see some tachycardia there as well with these patients. So, ABCs is a lot of what we're going to be looking for, right? Check that airway, make sure that airway is clear and patent, or listen. Make sure you listen to lung sounds. Do not skip lung sounds on these patients. Listen for your lung sounds, look for that accessory muscle use, and then look for those general shocky symptoms, right?
Yeah.
So that tachycardia is probably going to be present. They depending on how progressed they are, they might be hypotensive as well, as they're just leaking fluid everywhere, and their veins and arteries are really big, right?
When it comes to lung sounds, one, make sure an adults are listening to their back, because you're going to miss things if you don't. Think about tissue placement on adults. Kind of inverted if we're talking kids. Kids have a very anterior or front forward respiratory system, so you can hear them better from the chest. But I also want to really throw in extend listening to lung sounds to listening to the throat, because stridor is pretty obvious most of the time. There are times it's not. Take the extra 5 seconds, listen to their throat. If it's sing-songy, you're finding your answer a lot quicker.
Yeah. One other thing we didn't talk about that's always good to look for in patients that you suspect maybe are having some sort of allergic reaction is going to be medical allergy. So that's a fairly common thing. They might have like a bracelet. They might have a necklace or something.
Go ahead.
It's too bad Kylie's not here. Kylie, who you guys have met if you watched this before, she has a bee allergy, and she has a tattoo on her wrist that says bee allergy.
And then double check people's phones and their smartwatches. That medical ID is huge. If you don't have a setup, you should set that up. I've used that a lot, double checking that, they're allergic to whatever. And then, sure enough, here we are.
Yeah. Yeah. Use your resources. And that's a really good resource that we sometimes forget about. Or maybe people are just, when they're new, just embarrassed about it. Like it's an invasion of somebody's privacy. And I feel like if I was like over here and I couldn't breathe, like, yes, please look at my phone. You know what I mean? Like, you can look for my medical history. Yeah. It's fine. So you can save my life.
I mean, maybe I'm just a bad person, but I'm so nosy when it's like, go through that person's phone. It's like, already doing it. I get it.
Yeah. Oh, yeah. Your wife was asking for you to bring some milk home. Okay, cool.
Yeah. Your wife texts you. Oh, yeah. Sorry.
Yeah. Oh, yeah. Your dog's real cute, man. Yeah. Cool. So yeah, don't forget about that, right? Look for those things on top of the normal signs and symptoms, because you might find something there that can help. And again, at that point, you probably already know what's going on, but it just further cements that, like, okay, I'm on the right track, so I know what to do here. You're going to be doing your normal pulse ox can be kind of helpful here, but it's just a normal respiratory thing. So make sure you're monitoring pulse oximetry as well with these patients.
Right. And kind of mentioned it earlier is that, when we talk about a primary assessment of anaphylaxis, sometimes it's kind of an addendum, right? It's very quick. You walk in, seeing safe ABC, right? The whole thing, and you look and they're swelling, wheezing, stridor. You're going to start jumping into the treatment plans, which we'll get into, but you'll start jumping ahead of things. And it's not because you're not being thorough and you're not doing a good job, but you've got to buy yourself time, right? And that's more important sometimes than being like, according to my sheet, I didn't double check for bleeding first, right?
So I look at it like this, right? Like, we need to remember that we need to treat life threats. And even if you're like looking at the sheet, if you can come down and like, I'm assessing my airway and I have stridorous lung sounds with some wheezing as I'm listening. Okay, I've got that going for me. Checking my breathing. They're breathing 26 times a minute. It's shallow. They're working really hard to breathe. All those signs are there, right? And then I'm looking at my C's, my circulation, and they're flush. They have urticaria, all those things. I see all those ABC issues. Those are all life threats I need to manage. Real quick, do you have any allergies? And if they tell me yes, like, cool. Any chance that you got into that allergen? Yes, like, right. I'm not going any further, right? Like, most of the time, and maybe this is me being my particular way of doing things, but I'm very methodical when I work in the field, right? I'm going to be very methodical about asking questions and putting pieces together before I start treating, because once we give a treatment, there's no going back, right? Like, you inject somebody with something, like, you can't take that away. So in general, I'm going to put all my ducks in a row before I'm going to treat. This is one of those things where I'm going to walk in and you'll start to recognize it. If it's obvious, you'll recognize really quickly. Or this is thankfully a lot of the time where good dispatch information comes in of like, patient has an allergy to nuts and they got contaminated with something and now they're having trouble breathing. So you can come in on scene and be like, oh, visually everything's matching what I was told. You think you're having an allergic reaction? Cool. Epi, just right then, right? Like we can be pretty aggressive with
And these calls get chaotic really quick too. There's one in particular, like one call that I ran, anaphylaxis, that like we walked in, I could hear her before I turned the corner. And as I'm walking up, she allergic to anything? Bees, she gets stung? Yep. And it's already like, partner, start drawing it, you know, and you can gather so much information so fast. Think about reality versus your schoolwork, right? Those assessment sheets we give you, we're trying to stretch something that happens in 10 seconds into 10 minutes, right? So just understand too, the reality is when you see it firsthand, as long as you're paying attention, you know what you're trying or identify what you're looking at, you're going to be okay, but it's going to be moving a lot faster than you think it is. Just remember, take a breath, slow down. You got to be moving slow, doing things correctly at a good pace.
Yeah. So kind of jumping into treatments too. So the basic simple thing is going to be get some oxygen, right? Like if their airway is narrow, they're getting less air down that airway. But if we increase the amount of oxygen in that air, that's going to help them out, right? It's going to help oxygenate them. So be aggressive with your oxygenation. I don't feel like we realistically, at least at the paramedic level, because I have other things I can do, I don't use lead non-rebreathers, right? I've never really, I'll go for long times without a non-rebreather. But this is a good one that's really quick. Slap it on there as we're getting everything else ready, right? Because they're going to need that high level of oxygen. Maybe not ventilation, but they'll need that high level of oxygen. So non-rebreathers are pretty common with these patients.
I would say probably non-rebreather over ventilation, just depending on the circumstance, because if you think about it, and their tongue is so large it's swelling shut. Ambient oxygen just getting into their orifice is better than us trying to breathe through a tongue that's blocking a whole mouth, right? Make it make sense for the moment.
Yeah. So oxygen is going to be where we're at the basic level, and then realistically, it's going to be epinephrine, right? Like oxygen and epi, and then coming back to epi, coming back again to the pathophysiology, right? This one's really, I love epi for BLS because you can like really track exactly why you give it. So
it's satisfying.
Yeah, if you think about what epi does, it's a vasodilator, right? And we talked about vasoconstrictor, and we talk about how in the immune response, we have that widespread vasodilation, and that vasodilation allows increased cellular permeability, right? So if the veins get bigger and they start leaking, if we shrink them down, it's gonna have that opposite effect, right? So it directly treats that. And then if we're thinking about, that's the alpha side of epi, right? If we're thinking about the beta side of epi, it causes bronchodilation. Thank you. Yeah. I was going to say vasodilation again. It causes bronchodilation. And if we have one of the other things is the airway starts to swell close, we're going to open the airway up, right? Like it's a great medication that very directly works on the symptoms and signs that we see from anaphylaxis.
Right. It's honestly, watching an anaphylactic call was what made me want to become a paramedic on a ride along or on a clinical. It was a clinical. Not made me want to be a paramedic, but I think it opened my eyes to like, well, medicine is really cool. Like it's what pushed me away from being a firefighter and wanting to stay on an ambo. And like watching someone who's going like choking to death, wheezing, swelling, to like 10 minutes later they're laughing and having a conversation. It's like, what just happened? It's like magic when you see it work. It's cool.
So talking about epi, the dose is going to be typically 0.3 milligrams, and that's going to be intramuscular or IM. It's important to remember we talk a lot about EpiPens, but EMS is a business, and EpiPens, if you followed the news in the last 5-6 years, I don't remember when all that was popping off with the EpiPen spice, the spike in the prices, but they're very expensive, EpiPens. And so it's not very common. I don't know that there's really any EMS systems or hospitals that carry EpiPens. That's a rescue thing for patients to be able to have really minimal training at home to be able to save their own lives, right? So what we're going to typically have in the field is going to be a 1 milligram vial of epinephrine that we'll pull up into a syringe, and we'll inject it ourselves that way. So that's commonly what you're actually going to be giving in the field of EMS. And so you might see 0.3. I know locally the epi dose is 0.3 to 0.5 milligrams. That's the protocol here. As far as what you give, to me, like, are they really a very large person? They'll probably get 0.5. Are they more average size? Probably 0.3. But you you'll hear a lot about EpiPens, and like, how long you hold it and all this stuff. You're probably not going to give one of those. Your protocols may only allow you to administer an EpiPen if the patient already has it and assist with their EpiPen.
Yeah.
So know your protocols, but EpiPens are going to be 0.3 milligrams.
I usually caveat it with, and this comes with experience once again, so just don't, off the rip, you're brand new to EMS, don't assume that you know these things, because realistically you don't. And if you can't humble yourself and acknowledge that you don't know it, you need to look in the mirror a little bit. But how I would frame it is, if you walk up and they got an EpiPen and they need it right now, give it to them. There's no reason to withhold that. That said, I've had plenty of, hey, I ate peanuts 10 minutes ago. I'm just getting a little scratchy. We got time. Let's draw up our epi. Let's save them a little bit of money. I'm a big believer that patient advocacy does move to their finances, with the thought that, if need be in a life-saving circumstance, I'm going to use what I got to use. And if you have the EpiPen and it's going to be quicker, we're going to use it. But that's usually how I frame it. Just like Chris said, EpiPens are expensive, and especially we don't need to be putting somebody into potentially financial ruin because we decided to, use something where we could have drawn up our own stuff just as easy.
Or even just, they had the money to buy that EpiPen and we use it and they don't have enough money for another one, when we could have just used our own stuff and they could have hung out that EpiPen, right? So, and there are generics, right? There are cheaper versions of it, but it is still, I think they're like $300+ each. They're not cheap.
The last I heard was like $7.
Really?
Yeah.
It's an expensive thing.
This is also one of those that we don't often, especially at the basic level, because most of the meds are not pediatric approved, but this is know your pediatric doses for epi. Nationally, the one they look at is 0.15 milligrams. So if nationally NREMT is 0.3 for adults, 0.15 milligrams for pediatrics, know that number, because the last thing we want to do is we show up on scene kids are already raised the bar a little bit, but the last thing we want to do is like, okay, hold on. What's the kid's dose? I can look through it, right? Because we still got to make sure that this kid's getting the care they need. Know the number.
Yeah, that's a nice thing that's changed since I started. Is it used to be weight-based, and now it's typically just follows the EpiPen Junior, which is 0.15. And I would verify with your book. I think the National Registry is now following the EpiPen Junior dosing, which would be anybody below 30 kilograms or 66 pounds gets the pediatric dose of 0.15 milligrams, and anybody over 30 kilograms gets the adult dose. I think, does that sound right to you? Yeah. I would verify that if you're listening to this, like check what your book says and make sure you're following what your book says. But I believe that is where everybody's at now, is they're all kind of following that formula.
And that's one of those things too. That's a skill that you want to talk about. We could do a whole other episode about little skills to build, a good provider. But looking at someone and being able to eyeball a weight is huge, especially for that exact moment, of like, I'm not sure. When in doubt, you can always go with the bigger dose if need be, but be cognizant, check your protocols, know what your agency wants you to do there.
Yeah, 30 kilograms, like that's going to be a kid. Hopefully you have the parents there who have some sort of idea of about how much their kid weighs.
Right.
And then we need to remember they can burn through that epi. If it's a longer transport, ALS would be a really good thing to get it, because we have Benadryl that we can give to really help, because that's an antihistamine, block that histamine. We can do famotidine for the stomach stuff. We can do IV epi drips to continually give them some low dose epi to help keep those back.
Nebulized epi too.
Yeah, that's racemic nebulized epi.
That works.
So the paramedic scope, there's a lot that we can do for these patients. You at the BLS level can get there and really, you can be the lifesaver. But we want to, because they're going to go to the hospital and they're going to be treated for a while to make sure everything's good. So get ALS if you can. If not, then be ready for them to start to show those signs and symptoms again. Know your protocols to see about redosing that epi.
Right.
One thing I always thought was interesting, because like we just kind of figure it out based off of signs and symptoms, right? That's what's fun about EMS, in my opinion. So I was like, what about the hospital? Like, how do they call somebody like an anaphylactic reaction or whatever? Like, and so I talked to a nurse one time. I was like, do you guys have like blood work that shows like that there was a histamine response. And she's like, nope, same as you guys. We just have to find the story and give some epi if we think it's that, and watch for any changes to tell us we're doing the right thing, which
that's cool. We're not often on the same page with medicine. Not that we're not, but we're line of sight and they're lab based. So it's
they tend to have a lot more tools that we don't have.
Right.
And I was just always assumed that they had like some cool way, because that one time specifically, we brought in a patient that I treated as an allergic reaction, but I was like, I don't know. I wasn't 100% sure, and like asked the nurse, like, how are you guys going to figure it out? She's like, oh, the same way you did. I'm like, oh, cool, interesting. So yeah, give your epi.
Know your protocols, know your doses.
And then watch for the epi. We don't talk about this enough in EMT school. Like, watch what the epi does to tell you if you're on the right track, right? Watch for that airway to start to clear up. Watch for that heart rate to come down. It doesn't make sense if you think about it initially. You would think epi would bring the heart rate up, but as those veins and arteries clamp down, the pressure is going to go up, the heart rate can go down. So you'll typically see the heart rate come down. But watch for that hypertension to go away and all those things.
And don't be shocked if, like, they're tachycardic when you get there, and they're, like, well, I'm making these numbers up, but like tachycardic at 120, and then after a little while, they're still tachycardic, but at like 105.
Yeah.
That's a better number, or 106 for being math, right?
Or even if they don't change, but the blood pressure comes up and everything else starts to resolve, then you're on the right track.
Yeah, and honestly, one of the biggest things, notable relief on the patient's face.
Oh yeah.
Look at your patient. If they look like they can, that finally get that big breath, it's like, okay, we're moving the right direction. It might not be the right treatment for whatever else is going on underlying, but you're moving the right direction.
Yeah, maybe they're they're going to start talking better because their tongue swelling's going down. Look for this is definitely a whole picture thing. So make sure you're looking at the whole picture.
Yeah, and that tongue swelling can be aggressive. So be prepared to be aggressive with that airway, because if you're too late on an OPA, you're not getting it through that mouth.
Yeah, if you have the book that we use, the 12th edition of the emergency, whatever, blah, 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 the orange book, like there's a picture in there of somebody with a tongue that's like,
giant.
I mean, it's like this thing, this microphone, stuck in their mouth. It's huge.
Yeah.
Yeah. Once you're at that point, there's not much we can do. Right. So that's why we talk about being fairly aggressive with this, because once you're behind, you're very behind. And it can be really difficult to get back ahead of it.
Oh yeah.
I think that's kind of all we had.
Yeah.
What about you, Wade? Any other gems for anaphylaxis?
No, not really.
Cool. Yeah, I mean, like we said, just make sure you're being really thorough when you're talking about an anaphylactic patient, right? This is really, we talk about like treat the patient, not the monitor. This is a very much treat the patient, because there's not a whole lot of like objective stuff you're going to be able to find as far as like, oh, there's a very obvious like vital signs change. This is really a comprehensive what's going on with the whole patient, and being good at being a detective and finding out what's going on with it.
And the vital signs should be kind of obvious. You know what they're going to say. Their throat swelling shut. I wonder what their SpO2 looks like. Duh, it's going to be bad.
Yeah, I mean, it's just going to be, if you were to look just in, a small portion of the vital signs, right, instead of the whole patient vital signs, you're just going to see shock. Typically, you're just going to see shock, right? So that's when we need to extend out our view of what else is going on to figure out what this patient is specifically. So yeah, make sure that you're just doing your due diligence as far as that goes with these patients, and don't be afraid to give epi, right? And maybe you're not 100% convinced that's what it is, but if they have all the other signs and symptoms, epi is probably going to help them. So it just totally made me think of we'll end on a kind of a funny story I had, where it was myself and another medic that went on a call, and it was just one of those weird ones that like nothing made sense. Like we were both fairly new medics, but like had been on a couple years. He was a very good medic. And we're like just talking about it, and we're like, man, I don't remember specifically what signs and symptoms there were, but it was like nothing really made sense, but this was like the most likely that we had. So we treated with epi like it was anaphylaxis, or like an allergic reaction, because he was in extremis. He was having difficulty breathing, and it worked really well. And so I just remember like we took him to the hospital, and a month or two later, we both get an email from administration The guy he was so grateful. He had carved us a walking stick.
Sick.
So he just made a walking stick, and I think there's like feathers on it. And he like carved out like "Thank you EMS" and like painted it, and like it's actually really nice. And so that was like the coolest gift I've ever gotten from a patient. It was like this really it's like handmade walking stick. And so my partner was the one teching the call. And so we joked about getting like joint custody, like you'll have it for a year and then it'll live in my house and whatever.
Every other weekend.
Yeah, exactly. Like, so he's just always kept it. But every time, I see him, I just want to be like, hey man, how's our walking stick doing? That was a cool thing. It was like kind of a funny thing, but it was really cool. I was really grateful. It's one of those like, this is why I do this, right? Like this is really, really cool.
The walking sticks.
And maybe you listening, watching, maybe you'll have your walking stick moment of, you do something cool. And we don't feel that appreciation all the time. So it was really cool. Yeah. A little heartwarming story.
Yeah. It's a good one to end with.
Yeah, well, glad you're back, Wade.
Yeah.
We got Papa Wade here. Excited to have you back. So keep an eye out. We'll be back to trying to do just about every other week is what we shoot for. So keep an eye out for more stuff coming out soon. Check us out wherever else. We're on Spotify. We're starting to do video podcasts on Spotify, so you can check us out there. Apple Podcast. If you're just on YouTube, thank you. Please subscribe. We love subscriptions and all that. Leave some comments of anything else we can talk about or any other gems you have for other students. And we will see you guys or talk to you guys next time. Finger guns.